Just by show of hands, who in this room, if anyone, has heard me lecture before? Oh, good. Okay. All right. So I decided to use orange and blue, the CRPS colors, and you will probably hear me today use the words RSD interchangeably with CRPS because I'm old, and when I started it was RSD. And so for your benefit, if you hear me say RSD as opposed to CRPS and you hear Broach in the back screaming at me, which he does when I do this, just ignore it, and we'll move forward. Dr. Chopra and I have sort of an agreement. He does CRPS 101. He lays the foundation, and then I come along, being the loose cannon that I am, and talk about things that are a little bit different, because the way I do things are a little bit different. So you're going to get the best of both worlds today. You're also going to get a difference of opinion on some items, which is great because that's what the world thrives on. The fact that people in this medical business aren't always on exactly the same page, but most of what he says and most of what I say interface with one another. And when it doesn't, okay. So let me see. There we go. Technically, I am not real good at this stuff. There we go. Anybody who has ever seen my website, which I cleverly named drgetson.com, knows that it's really based upon the Arthur Conan Doyle character of Sherlock Holmes. And the reason is because I'm a mystery buff, I'm a Sherlock Holmes fanatic, and I have always believed that we are dealing with a great medical mystery, because no two people with this disease are the same, no two people with this disease have the same history or the same presentation. And for me, I got into this because of the fact that it was a mystery. So you will see references throughout to Holmes and quotes that he makes. And it starts with this one. So I want you to see a diagnosis, an explanation of a diagnosis, but I think it's just a wonderful, wonderful explanation of the disease. And I've underlined the words that I thought were important, like migrate and stabbing and shooting and burning, and the bottom part about the cold weather and the non-restorative sleep that you've heard about before, and the physical and mental fatigue, and the excessive physical activity and inactivity and anxiety and stress, and irritable bowel syndrome and bladder problems and Raynaud's and all these things that are there. And I think this is just a wonderful explanation that I got about this disease, and it really explains everything that you probably have ever heard or experienced or have seen, okay? The interesting thing is that it came from the National Fibromyalgia website. So what I put up there is actually from the fibromyalgia folks and not from the CRPS people. To step aside for a second, the slides, by the way, will be on the website as well, so it's not necessary to copy them and all the things that I read. But for my purposes, fibromyalgia is CRPS. So all those people out there that you're talking to that say, I have fibromyalgia and I have this, that, and the next thing, and it sounds awfully familiar. It sounds awfully like what you are experiencing or what you are seeing. The reason is that they're probably one and the same disorder. Now, I get into trouble when I lecture to doctors because there's invariably a rheumatologist or two sitting in a room and go, nope, you're wrong, okay, because this is, and so what I do is I put the slides back up and I say, but this is your National Fibromyalgia website and it's describing my CRPS patients. So what this does is twofold. Number one, it expands this disease from 5 or 10 million people to about 50. And secondly, it's an understanding of the fact that chronic inflammatory diseases are not necessarily all that different. And it would be great for me to stand up here and tell you this is my opinion, but it's also been in writing, and I put the two references up here because there have been at least 2 published references to the fact that these diseases are probably one and the same. Now, I start with that because I will tell you that you can treat the diseases the same way as you can treat many diseases the same way. And what I'm going to be talking to you about today is a little bit different in the sense that I want to talk to you about symptoms that don't include pain and dystonia and swelling and all those things that you, as patients with the disorder or caregivers of patients with disorder, already know. I don't have to tell somebody with a dystonic hand what it looks like to have a dystonic hand. or what it feels like to have pain. And I would be ill-advised to stand here and tell you that I understand the pain, although after 1,000 people, I have a fairly decent idea. What I really want to talk to you about today is, as I said at the beginning, some things that perhaps aren't a part of the armamentarium of knowledge that you're carrying around with you. My colleague, Dr. Schwartzman, wrote the only paper that has ever been published about the spread of this disease, and he did it in a journal called Pain in 2001. And what makes it interesting is the fact that the disease can spread, documented, up to 8 years after the onset of the initial trauma or symptoms. 95% of the spread is either vertically or horizontally, and 5% diagonally. Of all the people that I've ever seen, I've seen one that spread diagonally. Okay? So what I get sometimes is I see a patient who is seen by a doctor for an insurance company, and I'm not going to go down that road, but by an insurance who said, this disease doesn't spread. And we have doctors that treat this disease who say this disease doesn't spread. It does. I have to be politically correct today. They're filming me. So let's move on. There are actually 4 types of what I call pain, because I have to explain to you that pain is not the same. Your headache pain doesn't feel the same as your arthritic pain, which doesn't feel the same as your RSD pain or your CRPS pain. And so I've broken it down into 4 pains, which I call muscular, joint and inflammatory, deep bone pain, and for lack of a better term, burning pain. And the reason that I do this is this. I had a lady come into my office one time, and she was taking 10 to 12 Percocet a day for her headaches. And I tried to explain to her that there are headache-specific medicines, and why not try one of them? And so I ran out and I got her a Furoset, and I said, take this, I'll see you in a half hour. And I went about my business, and we're back in a half hour, and she said, it must be a miracle. What did you give me? My pain is gone. I said, something for your headache. So if you identify the fact that there are 4 different pains, and you identify the fact that muscular discomfort can be treated with muscular discomfort medicine and inflammatory with inflammatory, it really limits you to the amount of pain medication or pain-specific medication that an individual is taking. Because you're not going to get pain relief for a muscle spasm from an opioid analgesic. Okay, so to go back to the first slide, what sets this off? And here's something that I'm telling you that you all know. Stress, cold. People say the weather, it's really not the weather so much as the barometer changing. It's really, it's the human barometer. It is today real hot, and tomorrow the temperature drops down 10 or 15 degrees, and everybody's pain flares up. Why does it flare up? Because the barometer changed, not because the temperature got different. And so you will find that once that temperature plateaus at that other level, the pain level diminishes. Humidity, absolutely. The wetness, poor diet, vaccinations, certain toxins, prescription medication that you heard Dr. Chopra talk about before, and diet, which I'm going to get into at very great length later on. So others of my colleagues will say, can't be CRPS, can't be RSD because it's involving their stomach, it's involving their bladder. Can't do that. Why not? It's a disease of it's a centralized disease. The message goes from the arm to the brain and back to the arm. Okay? There's nothing in the human body that says when it goes that way, it can't go in a different way. So why can't it go from the arm to the brain to the bladder? And in fact, it really does. So I show you this, and I understand that we're not dealing with doctors here, but I will tell you, and I'm going to drive the video people crazy by walking, that there is a heartbeat here, and a heartbeat here, and a heartbeat there, and there's one there, and that's real slow. That's about 35 or so beats a minute, and a female heart beats about 70 or 75, and a male beats about 65 to 70. So when somebody shows up with that kind of rhythm, you got a problem. So it goes with this story. This patient went into the emergency room with that EKG strip. She was a 45-year-old female, and she had blacked out. Not really a great surprise. She had a history of diabetes. Her blood sugar was 160, which is reasonable. She had a history of thyroid disease, but her thyroid function studies were normal, and she had no other medical history except she was severely bradycardic. She had that 35 or 40 beat. Why? And why does this woman who has no heart disease have a pacemaker? because the CRPS migrated into through the sympathetics to the heart and slowed down the heart. Kids, it seems, have tachycardia. Their heart beats above 100. Adults drop down, and it's almost always women. I have 6 women with pacemakers who have no heart disease. All 6 of them dropped down into the 35 or 40. This woman happened to have passed out, which was good because they found out what was going on. She couldn't understand why she was tired all the time. Geez, your heart's beating half of what it's supposed to be. I guess you are tired all the time. So there are cardiac manifestations of the disorder. And you can get bradycardia, which is a slow heartbeat, tachycardia, which is a fast heartbeat, and atypical rhythms, meaning that it just doesn't beat like a metronome, like that regular heart is supposed to beat. It'll skip beats, it'll pause, and there's a whole constellation of ways that the heart can beat irregularly. So patients go into the cardiologist and they say, you've got bradycardia, and the cardiologist goes, okay, without realizing that there's a fundamental source for it. We have people that we have treated for bradycardias and tachycardias by treating their CRPS, and the heart rhythm corrects itself once we get the CRPS under control. Chest pain, okay? I have a patient who is now 63, who at the age of 51 had a massive heart attack. And the cardiac people walked in and they said, well, we're going to have to open heart surgery. And I walked in behind them and I said, I have some good news and some bad news. And he said, what's that? I said, the good news is we're going to save your life, and the bad news is I'm going to ruin it at the same time. And he said, what do you mean? And I said, well, they're going to open up your chest and they're going to give you a triple or quadruple bypass, and you're going to live, and you're going to live a relatively normal life, and the CRPS, which only used to be in your arms, is going to wind up in your chest, and you're going to have chest pain for the rest of your life. And here it is now 14 years later, and twice a year he winds up in the emergency room of the hospital with chest pain, which is not his heart. Because when they cracked his chest wall, they cut the nerves, and the nerves were then sensitized by the surgery, and so he has non-cardiac chest pain. And you can, by the way, tell the difference, because what I do when he goes to the emergency room, I walk into the room and I press on his chest. And then I back up so he doesn't deck me, because it hurts. But heart pain doesn't hurt that way. So once you can reproduce the pain, you pretty much know it's not cardiac. Visual disturbances, double vision, blurred vision, ocular migraines, I'll come back to in a minute, vision loss, photophobia, sensitivity to light. Patients coming into my room with not 1 but 2 pair of sunglasses in the office because the lights, the fluorescent lights bother them. Very, very common and not necessarily continuous. Ocular migraines are interesting. If anybody remember have an ocular migraine, okay? So you know that an ocular migraine, you don't get a headache. You get visual symptoms. I had one once, scared me half to death, okay? I was sitting there and I watched fireworks going off in front of me. I was in the house, it was a little scary. But it really looked like fireworks were going off, and it took me a minute to realize what was going on, and I just sat back and enjoyed the show. But you just don't get a headache. And so people come in and they say, wow, I got these funny floating things in my eyes, and that's an ocular migraine. Migraines, by the way, are horribly overdiagnosed in patients with CRPS because very rarely is it really a migraine. It's usually coming from another place. I'll get to that in a moment. Like right about now. Tension headaches. Anybody in the room with tension? Okay, okay. So you get those tension headaches that sort of seem to come from the back. The occipital nerves, by the way, sit in the back of your head at the bottom of the bump in the crease of your head. And if you get somebody comes in with a headache, I ask them to describe the headache. What does it feel like? And invariably, I get one of these things where it seems to start in the back and come through the front, or it starts in the front and seems to go through the back, or they can't tell. So I just walk around and I very nicely, gently press on the occipital nerves, and then I scrape them off the ceiling. And then you go ahead and you deal with the occipital neuralgia, which is really very easy to do because you can actually block the occipital nerves in an office very simply, and it takes the headache away for weeks to months at a time. And I do it with homeopathic agents. I don't even use conventional drugs because they work better. I take headaches away, and I'm not an interventionist, as you heard. I started out in family practice. I just take and I put a little tiny needle into each occipital nerve, and people just walk away for 5 or 6 months without those headaches. So something to think about the next time you get a headache. Get somebody to press on those occipitals and see if that's what it is. I love this word, otorhinolaryngology. I can't even say it. Otophobia is excessive sensitivity to sound. Turn the television down. And other people going, I can't even hear it the way it is. Okay? Or turn the television up because I can't hear it. Vibration. People tell me that the bass of a stereo, especially if they've got teenage kids who crank up the sound, and that bass, that vibratory sense of the bass, makes them crazy with pain. I've had people driving down the road in a car where somebody pulls up next to them and the bass bothers them. And I know that I'm telling you what you know because people are sitting in the audience going, okay. The bottom line is that vibratory bass gets into your nervous system and creates a problem. The bottom one there of hoarseness is really interesting. People get intermittent hoarseness. They get up in the morning, they get hoarse, they think they're getting a cold, and then it goes away. And maybe it comes back an hour or two later or a day or two later. But it just never really lasts. And it's that raspy hoarseness that you've had a million times but never really put one and one. And it comes from an irritation of what they call the brachial plexus. Now, in a minute I'm going to talk to you about the brachial plexus, which is a whole other entity. But the brachial plexus is in the throat, and you get the intermittent hoarseness. You have nothing wrong with your vocal cords. You have nothing wrong with your speech. You're not getting sick. You just get that temporary paralysis of the plexus, which causes the hoarseness. It's an amazing thing to get somebody who's been to 5 doctors who comes in and says, how often do you get hoarse? And they look at you like, oh, how'd you know that? It's a relatively easy guess because pretty much everybody with upper body CRPS gets it at one time or another. The brachial plexus, which we all know about and love, okay, comes down in the right-hand picture shows you, and this is very technical, Frank Netter drawings of the plexus. But the reason that I put this up is because of this. When you get brachial plexus irritation, it is not only in here in the arm, it's also in the chest wall, it's also in the armpit, it's also around the back, it's also up the side of the neck, and it comes up into the face. And so many people have plexus-related injuries that started their CRPS and think that means it's in their arm. That's where the plexus goes. And it follows the course of it when it starts initially, and it follows that pathway and goes into other places. It goes into the upper back. It goes into actually the outside of the deltoid muscle on the arm. So all those spots get sensitized because the plexus got stretched. How does the plexus get stretched? There's 1,000 ways. When you fall down, what do? Put your hand out. Put your hand out. Why do you do that? Because we instinctively protect our face. It's the way we were made. When you put your hand out, the other thing that you do is you lock your elbow. Nobody thinks about this, but next time somebody sees somebody fall, the hand goes out and the elbow gets locked. And so you go to a hand surgeon because you cracked your wrist, and the hand surgeon says you broke your wrist, and nobody ever says, what'd you do to the elbow and the shoulder? And the answer is you did a lot more damage to the elbow and the shoulder than you did to the wrist, because the wrist you put in a cast 6 weeks later, you take it off, you do a little occupational therapy, physical therapy, it's all better. But you're jamming that shoulder up, which means you're stretching the plexus. And when you stretch the plexus, if you already are on the verge of nerve-related problems, the plexus is not real happy and doesn't go back. Ergo, most of the, I won't say most, but the largest percentage, if somebody says to me, what's the greatest percentage of CRPS patients you see, is people that injure their plexus from falling or pulling or yanking or whatever it is. And some of these people have facial problems and go to the ear, nose, and throat person and they say, well, you have trigeminal neuralgia with the trigeminal nerve. Trigeminal nerve is affected by the plexus. So it's not trigeminal neuralgia. It's the CRPS migrating up into the face. I have seen way more than I ever want to see people whose teeth are literally falling out of their mouths. And they think it's from the medicine, and it may be. And they think it may be from poor hygiene, which it is. But remember now, this is disease that affects the nervous system. The nervous system has nerve roots that are in the mouth. Therefore, it affects the nerve roots in the mouth and teeth begin to fall out. I have 19-year-old people, almost always girls, with full dentures because their teeth are falling out of their mouths. Okay. So if the teeth begin to go bad and you're not putting an actic in your mouth with all the sugar and all the irritation from the actic. It's a consideration that perhaps the problem is coming from the CRPS. Anybody ever see a rash like this? This girl, this is one, and that's the second picture of her arm. This is when she goes into a flare. This is not skin. This is not a rash. This is in the skin. This is underneath the layer of skin. See if I can get the other one back. Okay, that's her abdomen. It actually goes around to her back and up into her chest. And when she goes into a flare, I don't even need to see. I mean, if you just showed me her arm, I know she's in a flare. It has a fancy medical name called livedo reticularis, and it is not only in this disease. You can have livedo reticularis and not have CRPS. But when you see something like this, it's pretty riveting. The lesser version of this is the skin of the arm begins to look like a honeycomb, almost looks like a beehive. And it's faint and it's a little purpler than the regular skin, and it may come and go and fade. This is a rather extreme version of a skin type of rash. I say rash, and again, I don't really mean that to mean rash. The other thing that I will tell you is there's a condition called neurodermatitis. Neurodermatitis are skin lesions that look like, when they start, whitehead pimples of acne. They start as little tiny whiteheads, usually on the affected limbs, more often on the legs than the arms. And they itch. And they start like little whiteheads, and then you scratch them and they get infected because the immune system is compromised. And they may be 5 or 10 or 12. And they come from the CRPS. And if you go to a dermatologist, and the dermatologist is sharp, they will tell you this is neurodermatitis. And there really is no treatment for them other than to put some topical cortisone on them and stop the itch so that you don't get infected from scratching them. But they're very common, okay? And they come and go at will. They may come and last for 2 or 3 weeks. You may not get them for another year, and then you may get them sequentially over a period of time. That's another dermatologic issue. DERCUM'S disease, of which I've only actually ever seen 2, are lipomas. Lipomas are fatty tumors, and they will tell you that fatty tumors are benign, which they are, and most dermatologists just say leave them alone. These just happen to be fatty tumors that hurt. And they hurt because they are a manifestation of the CRPS in this rather limited disease. There is a doctor whose name escapes me at the moment, but she's in Arizona, who's actually got a clinic to treat DERCUM'S disease. I hadn't even heard about it until about 5 years ago. And nobody knows what it's from except in people who have CRPS and get this. And I will tell you that the 2 people that I saw said that these lipomas were actually more painful than their affected limb. And there's not a thing you can do other than to try and get the CRPS under control. Dr. Chopra mentioned earlier gastroenterologic, and I have to talk for a moment about gastroparesis. Gastroparesis is the slow movement of food through the digestive tract. Now, let me simplify it a little bit. When you eat, the food goes down the esophagus. There's a valve that opens up to let the food into the stomach. The stomach is filled with acid. The acid breaks the food down. There's a valve on the other end of the stomach to let the food go out through the passage of the small and large intestine. That's the way it goes. The problem is that with gastroparesis, the first valve opens, the second one doesn't. And so the food sits in the stomach. And food that sits in the stomach, rolling around in the acid, putrefies. So you now have putrefied food in your stomach, which is making you sick and nauseous, and then you gag or you throw up. But the brain, after a period of time, is saying, hey, it's been 6 hours since I ate, I need to eat something. And so because it's been 6 hours, you start to eat, but there's no room at the end because the food hasn't gone out the other side. So the only place for that food to go is to come back up, which is why so many people vomit, because it's not getting out. Now, there's a relatively simple way to do this. There is a study called a gastric emptying study. It's done in the X-ray department of a hospital. They feed you hospital food, which is enough to make anybody vomit, and then they measure the amount of food in your stomach and how much has exited your stomach over a 4-hour time frame via X-ray. And they tell you that by the end of 4 hours, you should have 90% of the food gone, and you only have 40% of the food gone, and now you understand that you have gastroparesis, which explains why you're vomiting and why you're nauseous and why you feel like you can't eat. And it's a problem. There are treatments for it. We have some doctors up by us, I'm in New Jersey, who will put Botox into the pyloric sphincter and will get that valve to relax so that the food exits. And you get a more normal, not normal, but a more normal flow of food from ingestion to elimination. The best thing to do is eat small quantities frequently to get the load on the stomach reduced. But this is very, very common. I have 2 females that we couldn't fix it with, and they wound up having to do surgery to get this thing to work. And what makes that story interesting is that the only 2 females that I've ever seen it not work on are sisters, both with the disease. Other things, diarrhea, constipation, especially opioid-induced constipation, biliary dyskinesia, dysphagia. Dysphagia is difficulty swallowing. Okay, food seems like it gets stuck. Okay, which is largely because the esophagus isn't opening and closing like it is, because the esophagus is controlled by the nervous system. And so the message from here to here is again impaired, it's misread. Biliary dyskinesia means that the bile ducts in the gallbladder, if you have one, or in the liver, if you've had your gallbladder removed, are not doing their job in releasing the bile and breaking down the food products that the bile is supposed to decompose. And so what happens is that you begin to get gallbladder symptoms of pain in the right upper quadrant of the abdomen, but you don't have a gallbladder. So how can that be? Because the liver has taken over. Or you get gallbladder symptoms and all the diagnostic workup is normal. So if it's normal, no surgeon in his or her right mind is going to take out a normal gallbladder. Something to think about, biliary dyskinesia. Difficulty voiding or excessive voiding, or hey, every time I cough and sneeze and laugh, urine dripples out. I'm 27 years old, I have to wear a pad because I leak urine. I mean, what could be more upsetting and embarrassing? Okay, it's not because the people have interstitial cystitis, but rather they have neurogenic bladders. Neurogenic bladder simply means that the nerve impulse from the brain to the bladder isn't right, so it doesn't know when it's full, it doesn't completely empty the bladder, and so you think you're emptying your bladder, just like you think you're emptying your stomach with gastroparesis, but you're not emptying your bladder, and therefore small quantities of water have no place else to go but leak out. Interestingly enough, the easiest way to treat this is in the hospital with an epidural catheter. Is to be in the hospital, lumbar epidural catheter into the back, because I've seen time and time again where we can get that to resolve itself for months to years at a time. But you go to a urologist, the urologist says you have interstitial cystitis, and it's not. Gynecologic, polymenorrhea, frequent menstrual periods, dysmenorrhea, pain, menomenorrhagia, period, bleeding between periods, and secondary amenorrhea, meaning skipped menstrual periods. Okay. All of these, any one of them, all of them, some of them. Okay. The second paragraph, however, is interesting, and that is that I have now seen, I think it's about 15 women who get pregnant with CRPS. We take them off the medicine, they get to the 3rd trimester of their pregnancy, and all their pain goes away. I mean, it just goes away. They come in one day and say, I don't have any more pain. I have a woman who's had 4 ectopic pregnancies, and she can tell me the day she gets pregnant, because as soon as she gets pregnant, her pain goes away. And she's lost 4 pregnancies, and the pain comes right back. I had a story, I tell people about this. I had a story of a girl who was 17 years old, had CRPS, and got pregnant, and I think by accident. Okay, her pain went away. She delivered a healthy baby, she breastfed the baby. At the end of about 6 months, she stopped breastfeeding the baby, the pain started to come back. But it never came back quite as bad. A couple of years later, 2-3 years later, she was in a minor accident, pain came back full-fledged. She got pregnant, not an accident. I think she got pregnant the second time to get rid of the pain. Same story, okay? 6 months later, pain goes away, she breastfeeds the baby, everything, pain comes back, not quite so bad. She was really, really good. She was probably at about 20% of her original pain. I lost track of her, and I saw her many, many years later, maybe 10, 12 years later. She had a 3rd child. I said, please don't tell me. Okay, she said, no, this one I just met a guy, we got married, he wanted to have a baby, and she was great. She was in complete remission, but she had that peak and valley every time she got pregnant, and it's not unique. Which is not to say that if you're 17 years old, you should run out and get pregnant to get rid of the pain. I had a mother get very, very angry at me with her daughter, and I said, well, if she got pregnant, so can't do that. Okay, Syncope, again, articles about syncope, meaning blackouts or drop attacks because the autonomic nervous system is malfunctioning. And to that end, let me show you this story. Okay, a 44-year-old woman with long-standing history of CRPS is involved in an accident which accelerates her symptoms. She injures her brachial plexus. We're now experts at what that is, and has classic brachial plexus RSD symptoms. But she starts having drop attacks. I mean, she's walking to the elevator in my office building, and all of a sudden she's on the floor. It's not like she's swooning, she's just down. She's just on the floor. We do MRIs, we do EEGs, we do carotid ultrasounds, we do everything, and it's all normal. And then I put her in a cervical collar, and they said to me, why did you put her in a cervical collar? So what I did was I sent her to the hospital, to the x-ray department. I said, I want you to ultrasound her carotid artery. They said, we already did that, it was normal. I said, I want you to do something different. I want you to ultrasound the carotid artery on both sides, and then I want you to turn her head and ultrasound the carotid artery on both sides, and then turn it the other way. And on the side of her plexus injury, she had almost completely blocked off her carotid artery. So every time she turned her head the other way and artificially occluded her left side, she did not have enough blood flow on the right side to get blood up to her brain, and down she went. As soon as we put her in the collar, which prevented her from going all that way, she stopped having the attacks. That's why I follow Sherlock Holmes mysteries. Vertigo is common. You treat the RSD, or I did it again, you treat the CRPS and the vertigo gets better. But vertigo is very difficult because it's transient, and if you're well enough to be driving and you're well enough to be functioning, vertigo is a real big problem from falling down steps or being in a car behind the wheel. And you really have to kind of be careful of the vertigo and be cognizant of the fact that it may come for an hour and it may come for days or weeks on end. Same story, treat the underlying CRPS problem, the vertigo gets better. Next story, 37-year-old female worker in a casino was struck by a money cart. In the days in New Jersey where they used to actually have carts, now everything's paper, but they used to actually have carts. And the guy pushing the cart lost control of it, and it rolled down this little ramp and went right into her thigh. And then a year later, her sister, who was a police officer, was broadsided in a patrol car, and the handle from the door went into the same place on the same thigh as the woman got hit with the cart. And they both wound up with exactly the same CRPS and exactly the same spot of exactly the same limb that spread vertically to exactly the same path. They were 2 years apart. Now, there is a question about genetics, and you will hear people tell you that there is no genetic predisposition to this disease, to which I say baloney. 1 family, 2 families, okay. 18 at the time that I made this up a couple of months ago, now almost 24, 25 families where more than 1 member of the family has documented CRPS. To that end, okay, I found a company called Neuroscience. We are starting to do genetic testing. So if anyone in the room has a family member that has documented CRPS, I would like to speak to you after I'm done talking. Anxiety and depression. Please understand there is a difference between depression and being depressed. We all get depressed. It is normal to get depressed. You fail a test in 5th grade, you get depressed. It's normal. So when I say to people, you're depressed, they go, I'm not depressed. And I say, wait a minute, okay? You have a chronic disease that's taking your life away. You should be. I'm not saying that you're mired in depression and supposed to be taking pills, but it's upsetting. And so people go to doctors who give them benzos. They give them Valium or Ativan or Xanax or one of the generics thereof, which, by the way, makes depression worse. Because recognize, if you've got 2 200-pound people sitting on a seesaw and you take one off, this is what happens. So if you take the anxiety away with a benzodiazepine drug, what happens to the depression? Now, antidepressants don't work. And the reason that they don't work is because they don't do what you need them to do. What an antidepressant does is it artificially, okay, shoves a serotonin or norepinephrine or one of those drugs into your brain. And that's not what you need. You need your body to be making serotonin or norepinephrine. You don't need artificial stuff. You need real norepinephrine. You need to get your body working. In a diabetic, who we give insulin to, we give insulin because the pancreas doesn't make insulin. It's not ever going to make insulin. Wouldn't it be great if we had a drug that could stimulate a diabetic's pancreas to make insulin? There are nutraceuticals, which I will talk about in a little bit, that will stimulate the human body to make norepinephrine and serotonin. But if you keep giving it Prozac et al., okay, it's going to say, why should I work? You're doing it for me. You're taking that pill every day. And this is why SSRIs and SNRIs don't work. I have 8 people with MS. They're all women. Okay. All 8 of the RSD/MS patients. 6 of them, we treated the MS in all 8 of them, but in 6 of them, when the MS got better, the CRPS got better. To the point that in 5 of the 6, I don't have to treat their CRPS. As long as they maintain the treatment for the MS, their CRPS, I don't know why. I'm just kind of tossing it out there. Here's one of those times that Dr. Chopra and I are going to disagree. He said there's no diagnostic test for CRPS, and I disagree. I've been doing thermography for 32 years. Thermograms are heat pictures, and I maintain it is the only diagnostic test available that will absolutely positively show you CRPS in absolute living color. I have been doing this for 32 years, and I will tell you that every time somebody comes in and we do one, we get pictures like you're about to see. And the reason is this. Thermograms, which are infrared images, image the function of the nervous system, which is that function of the nervous system that we can't image any other way. So what happens is that it provides an image of the sympathetic portion of the nervous system, thereby allowing you to graphically see what is malfunctioning and where. Now, before I show you the thermogram, anybody in here ever have one? Anybody in here ever see one? 43-year-old woman is sitting on an airplane. She was actually on Spirit Airlines in sandals. She cut her foot on a piece of wire that was sticking out where it shouldn't be sticking out. And 2.5 years later, when I saw her, in addition to having a bad foot, she had all those things you see in orange at the bottom. And she had been doctor to doctor to doctor, and nobody seemed to have any idea why a woman who cut her foot spiraled downhill in the fashion that she spiraled downhill, having pain in the left side of her chest and in her face. But if you look at that, there's a common denominator, which is, okay, left, 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 left. So we took some pictures. Now, this is a thermographic image, and please understand that this is the left side because she's standing this way and facing the camera, okay? This is her right foot turned outward. I have circles up there marked 1 and circles down here by 2. Please understand that the premise of thermography is that the human body is a symmetrical entity, that the left side of you and the right side of you are the same within reason. So when you look at these pictures, and only a handful of you have ever seen thermographic pictures, it should be clear to you that the right leg and the left leg look different. It should be clear to you that the right foot and the left foot look different, and there's a color scale on the far end. And the difference between them is 1.1 and 1.6 centigrade degrees, which is physiologically impossible except in 2 instances. 1, if you have a blocked blood vessel, which this woman clearly did not, or 2, if you have nerve injury, because after 6 months, the nerve injury shows cold. So I was able to look at this and say, you know what? This is a CRPS picture, for which the lawyer was very grateful, but even more grateful when I said, here's some more pictures. This is the same leg, because you can recognize how you see it, just changed in a different position, but it's also on the inside of the foot. And interestingly enough, I thought it was there, but I'll show you on the other one. Other parts of her body did, as I'll show you in a minute. This being the first day of football season, here's a quick other story. A woman goes to the Eagles, I'm allowed to say that in Dallas. A woman goes to an Eagles practice session. She's sitting on the 3rd row of the stadium, and the players are throwing footballs up into the stands. It's a gimmick. And the punter kicks a football up into the stands, and some guy catches it and decides he's going to be the next coming of Roger Staubach. I'm in Dallas. and he's going to throw the football down to the field. Well, unfortunately, he wasn't, and it didn't. And it never made it to the field. It made it to her face. So what happened was, as this football was hurtling down at her face, she did the same thing you would do if you fell. She took her hand, put her hand in front of her face. And the football hit with the tip into her palm, okay, pushing it back to her face and breaking her hand. So what happened was she went to the local orthopedic surgeon who said, you broke your hand, and he put it in a cast. And months passed, and this woman started to get worse. And this is what her hands look like thermographically. The left hand is on the far side, away from me. And you see that there's a very big difference, not just in the wrist, which are the numbers 3 and 4 at the top, but also in the back of the hand and down into the fingers. By the time I saw her, she had a bad hand, graphically abnormal like that, but she also had problems up into her arm. This is the left arm closest to me. So what we were able to see was visual evidence of nerve dysfunction of the sympathetic nervous system. Now, it's important for me to tell you something that I would have done, but I didn't want to interrupt Dr. Chopra. He was talking about EMGs and how EMGs are motor function studies, and so if you have CRPS, which is a sensory abnormality, it's not going to work. And he talked about the pain, and you've heard all that, but here's what you didn't hear. If you take a patient who has a brachial plexus injury and you do an upper body electromyogram, EMG of them, the EMG is going to show up that the patient has carpal tunnel syndrome. Let me repeat that. An EMG on a CRPS brachial plexus patient shows positive for carpal tunnel syndrome, which the hand surgeon then goes and operates on because they say, hey, the EMG is positive, that's why you have pain, you have carpal tunnel syndrome, which you don't. So what happens to the CRPS when you get operated on for a nerve injury that you don't have? It's like throwing gasoline on a fire. So when patients walk in and say to me, I have CRPS, I'm going to go have an EMG, I said, run the other way. Not because it hurts, not because it can set you off, which is bad enough. The worst case scenario is somebody's going to want to operate on you. Okay. And if you have a plexus injury, here's another great one. They tell you that you have an ulnar nerve problem and we have to move the ulnar nerve. What? Just move me into a place where I'm going to be in intolerable pain for the rest of my life, because it's not real. And to me, that's the gravest danger of EMG testing. So I add that as an aside. So, all right, so people want to know about ketamine, and we'll talk about ketamine, and I will tell you that, as I said earlier, Dr. Schwartzman and I wrote the protocols that everybody is supposed to be using, but unfortunately are not. And there's a lot to be said about ketamine, and here's the bottom line of it. I do not now, nor did I then, believe that ketamine is the last step along the way. I believe that ketamine is a device, it is a drug, it is a product to get people into a realm where you can do other things to make them better. I think it is the best available treatment that we have on the market today to reduce pain. But there's got to be more to it, because otherwise you're going to be taking ketamine for the rest of your life, and that's never been the goal. I have this silly little anecdote that I tell people, but they understand that. If you live in Montana and you look out your backyard past the edges of your property, there's a white stallion out there and roaming around, you decide you want that horse. Until you get that horse and bring it into your corral to break that horse, you're never going to be able to do what you want with that horse, because he's in his territory out there. He's running wild and you can't control him. You need to bring him in and get him into your realm. That to me is where ketamine belongs. When people are out there with so much pain, so much dysfunction, so much sensory overload, you need to get it to a point where you can begin to work with them. You heard this morning, before you start physical therapy, you got to control the pain. Okay? This to me is the best way to control the pain. But there's more. Okay, ketamine is given IV, oral, intranasal, and topically. I want to tell you real quick, intranasal ketamine in my world doesn't work because it leads to a real diagnosis of interstitial cystitis that you never get rid of. So anybody who tells you that they're using intranasal, two things happen. One, I'm using it one spray 3 times a day, 2 weeks from now, one spray 4 times a day, 2 months from now, one spray 8 times a day, 6 months from now, 14 sprays 72 times a day. Okay, and by the way, I can't hold my urine. So, in case you didn't know, I don't like intranasal. 9 years ago, there were 3 of us, Ron Harbit, who introduced ketamine to America, Dr. Schwartzman, who's now retired and sitting on a dock fishing someplace, and I'm jealous, and myself, and last count, there's over 60 places in America that we know ketamine are actually being given. And having done over 300 people, I'm getting about an 80 to 85% improvement rate, meaning that people are getting better. People are not getting cured, people are getting better. My first and only paper that was written in a journal, Dr. Schwartzman and I wrote a paper that talked about the use of ketamine in surgery. Here's the story. If you're going to have surgery, and I don't care if that surgery is a bunion, or it's an extraction of a wisdom tooth, or anything in between, you need to have ketamine during the surgery if you have CRPS. Because if you don't, you run the very real risk of spreading the disease via the surgery. I guarantee you, if you walk into any orthopedic surgeon in the world and you say, and they say, okay, I have to have a knee replacement, they're going to say, I can't do it, you have CRPS. Can't do it. Okay, going to spread your disease, going to make you worse. When we wrote the paper, I had 20 or 21 people, I forget, that were my part of the study. Since then, I've had another 24. I have never seen anybody spread the disease as a result of surgery, because every one of them gets intraoperative ketamine. And I write the prescription that says, this patient must have whatever the dose is of ketamine intraoperatively. And I do that because I had a surgeon call me on the phone one day and scream at me saying, you wrote must, so I have to do it. Yeah? That's why I wrote it. Well, what if I don't want to? I said, then the patient will leave the hospital and go to a hospital or somewhere to get ketamine. Because once you write must, if you don't get it, it becomes medical malpractice. So I tell the patients, you go into that operating room and you say, if you're not going to give me ketamine, tell me now because I'm leaving. Because if you don't insist on it and you don't get it and you spread the disease, it's your fault for not insisting. It's your fault for not standing up for your own rights as a patient. I'm sure that there's going to be a case come along where somebody's going to spread it, and we did the best we could. It's inevitable. But at least then, we all knew we did the best we could do. And you can't do any better than that.
You mean like an IV dose of it?
IV dose, intravenous. Usually somewhere between 75 and 125 milligrams, depending upon the nature of the surgery and the longevity of the surgery. See, my second and last Sherlock Holmes quote, the one I live by. Okay, so Dr. Chopra mentioned pamidronate and originate. I want to just tell you very quickly, pamidronate is a very, very safe drug. There's about 7 studies in the world literature in the past 15 or 20 years. They were all done on CRPS 1 patients, not CRPS 2 patients, except for the last one, which was done on chronic low back patients. In every one of the pamidronate studies, people are getting better. I can't find anybody anywhere in this country that is doing pamidronate intravenously, which is why come November I'm going to do just that. I'm going to give patients up their pamidronate, contingent upon dental health and renal function, but we're going to give, and we're going to see what happens because nobody knows. It's not sedating, it's not ketamine, and if you have decent teeth, you're not pregnant, and your kidney function is good, and you take necessary precautions, I think there's a real chance this may help. Neuridronate is the second generation of pamidronate. The study was done in Italy. That's the 100% study. There's a company going to be doing a research study starting the end of November in this country that's going to last 18 months, so don't expect to see neuridronate here in the near future. I'm not sure whether it works or not. I may or may not be part of this study, but they're really being aggressive with the study. The Italian study makes it look like it's the second coming of chocolate, but Again, it was all CRPS 1 patients at the earliest onset of the disease with very specific criteria of having one limb disease, no internal manifestations. And it's, you know, I mean, you're kind of skewing your results when you do that. So we're not sure. Okay. So I want to spend the last 5 or 8 minutes here talking about just something that hardly anybody talks about except for the young lady that preceded me, and talking about food and diet. Thomas Edison said the doctor of the future will give no medication, but will interest his patients in the care of the human frame, diet, and the cause and prevention of disease. And Hippocrates said, let food be your medicine and medicine be your food. And to that end, here are 7 foods that you absolutely positively have to go home and throw out. Okay, aspartame, which is in every yellow, green, or pink packet of artificial sweetener, and pretty much every soda, every diet soda. Additives like MSG and nitrates. MSG is also called natural flavor. Okay, if you go to a Chinese restaurant, you know how you feel afterward, and it's not hungry in an hour. Sugar, fructose, and simple carbohydrates, caffeine, yeast, and gluten. I'll come back to in a minute. Dairy and nightshades. 7 foods or groups. Now, my patient population is told, go gluten-free. Go gluten-free. And every one of them every one of them has gotten better. Now, when I say better, it's all increments. I'm not saying they just woke up one day and say, I'm pain-free. But they all feel better. Number 1, go gluten-free. Number 2, eliminate or reduce dairy. Number 3, eliminate anything white. White sugar, white flour, white rice, white anything. Okay, because remember, sugar is just, regular sugar is just like the body's going, wow, and then you're done. You go gluten-free, you go dairy-free, or as best you can get, you will feel better. You will feel better. Gluten-free diets are just a commitment. I mean, it's a commitment to getting better. And here's why. Gluten doesn't digest well, and gluten is a highly inflammatory food. This is an inflammatory disease. We don't knowingly try to over-inflame something that's already inflamed. But yet we eat foods that make an inflammatory disease more inflamed. It's illogical. Gluten sensitivity is an autoimmune disease. Anybody in here ever hear the term that CRPS is an autoimmune disease? So now you want 2 autoimmune diseases? Stand in line. Okay, can I have another one, please? I already have one, but I'd really like to have another one. So you have to get to the cause of the problem. And if you leave here with nothing today other than this, it is my belief that there's 2 things that have to be looked at. Number 1, we have to start eating better. And I don't care if you have CRPS or if you have rheumatoid arthritis, if you have diabetes, you have to start eating better. Because we're not eating what we're supposed to be eating. And I don't want to go on a soapbox, but those of you in the room that are as old as me remember when we didn't have this discussion because food was food. If you eat right, okay, you feel better. It's just really that simple. And so the New England Journal of Medicine listed 55 diseases that can be caused by eating gluten, and I'll just give you a moment to peruse that list that's up there. The one in orange is interesting. That's why I changed the color of it. So what's a gluten-free diet include? Well, here's some things. And again, you're all going to have the slides, so it's not necessarily something you have to take home with you, but there's a lot of things you can eat. And you see in here, by the way, that it says preferably organic. And I understand that there are financial considerations to organic food. When you can get organic, it is always preferable. If you can, and you can buy from local farms so it's not transported across the country or flown in and X-rated in airports, and it's always preferable. That's the second one. And free range, whether it's chicken or meat, is always preferable because we're getting back to natural. And some things to avoid. I mean, just wheat. Yes?
There's been a study out that showed that people who had the gluten-free diet eventually started reacting the same to corn products because they put corn in so many of his stuff. And corn isn't on your list of things to avoid.
Okay, if you didn't hear her, she said that there is a study out that shows that people who go gluten-free begin reacting the same way to corn, and corn isn't on the list, and my answer to you is it should be. Okay, because if you're going to go gluten-free, then you have to take corn out of your diet and anything that contains corn, either in corn syrup or anything like that, and thank you. And here's some things to eliminate. This is called the list of everything that I eat. Wow, what's left? I'm not ever going to eat again, so I don't have to worry about gastroparesis because I have nothing to eat. Okay, last topic, neurotransmitters. I mentioned earlier neurotransmitters. Neurotransmitters are brain chemicals. Words that you've heard: serotonin, norepinephrine, epinephrine, GABA, dopamine, words that you've had bantered about. There are more neurotransmitters in your stomach than there are in your brain. And how many of us sitting in the room have really good stomachs? Show of hands. How many have no problem whatsoever with their stomach ever? Good, everybody just went deaf. Okay, terrific. Neurotransmitters are controlled predominantly from the stomach and affect the brain. So as I was telling you earlier, okay, I don't want to give a person serotonin. I want to give them something that causes them to make serotonin. So what we are doing in the office is, outside of the box, we are looking at conditions related to neurotransmitter dysfunction, and this is some of them. And by the way, this is not my list. None of these lists are mine. If it's not footnoted, it came from a study or a journal. And because everybody in the world knows what fibromyalgia is, and 10 people in the whole world know what CRPS is, they keep talking about fibromyalgia, but you now understand why, if you buy into my concept at the beginning that they are the same entity, then those things that apply to fibromyalgia certainly apply to CRPS. Okay? So we're looking at this, and when the level of neurotransmitters can't relay the electrical signal from one neuron to the next, you get an imbalance. And when you get an imbalance, you get disease. Now, the people that work with the RSD Association who are way smarter than me and work in labs are looking at neurons and glial cells and trying to figure out why people get this disease, because the neurotransmission isn't right. Good. We need people like that. I'm not one of them. Okay. The real reason, however, is that if I can't figure it out, and to date they haven't figured it out, at least I know what to do about it. Because if I can balance your neurotransmitters, okay, it's a lot less important to me, at least temporarily, why they went out of balance in the first place. Unless I can't keep them that way. And then it becomes important again. Low comes from prolonged stress. None of us have that. Genetics, we talked about that. Diet's low in amino acids. Well, we all know we eat horribly. Medications, most everybody's taking some kind of medications, and nutritional deficiencies, which may not necessarily mean that you're not eating right, but that you are not absorbing right. And high come from steroids and imbalance of other neurotransmitters, which is to say that if one is wrong, then probably a whole bunch of them are wrong by the domino effect. So there are excitatory neurotransmitters. The list is on the left there. You heard Dr. Chopra earlier talk about PEA. I can tell you that of this, the preliminarily in the study that we're doing, the key is going to wind up being the last one on that list, which is norepinephrine. I don't have any answers yet. I can only tell you that we've started and we're working with this company and people that understand this inside out and upside down, and they're teaching me. Inhibitories are serotonin, the others that you've seen. And then taurine, which seems to be a real deficit in almost everybody that we've tested so far, which helps promote calmness and healthy sleep. And again, when I asked how many of you have a normal stomach and I got no raise of hands, here's another question. How many of you really sleep well? One. One.
We hate you.
And so what happens is when you see accumulation is caused by drugs like anticonvulsants and antidepressants, what's our main source of drug therapy for the treatment of CRPS? Anticonvulsants. And what else? Antidepressants, okay? And for the rest of the people, okay, who are anxious as opposed to being depressed, then we can get depletion from benzos. And again, just another list of things. Again, in the middle, you talk about norepinephrine, which controls anxiety and stress. And certain things that work as a 5-HTP works as a painkiller and an antidepressant. Remember, I was telling you earlier, there's ways without the SSRIs and SNRIs. The DLPA works as an opiate agonist. Methionine reduces depression. Fish oil is just something everybody should take every day anyhow. And manganese and B6 and zinc. And we're also working on looking at vitamin therapy up there. We are looking at the effects of actual B12, not the kind of B12 that you get a shot of, but absorbable B12, which, by the way, is absorbed in the stomach, where you can't absorb things because your stomach isn't working right. We're looking at B6 and other B vitamins. There's a lot of things that aren't part of that standard stuff you're reading that, hey, take this and do this, because we're just of the belief that there's more to it than this, and it starts with the fundamentals. And I think sometimes, and I've always been this way, I think sometimes what happens is that we're looking at a forest and forgetting that it's made up of individual trees, and those trees have been studied and studied and studied for thousands and thousands of years, and there's just a wealth of data out there that the medical community of the Western world is ignoring. I mean, you don't have to go very far to find the stuff that I find here. We just don't talk about it. We don't look at it. You know, who would think that I'm standing here in front of a group of people talking about CRPS and telling you to change the way you eat? But it makes a huge difference. Hormones, another thing, if there is in fact a genetic predisposition to this, and if in fact 80 or 85% of the patients I have ever seen are women, and if I don't lead any credibility to the comment that I get from some of them saying that the reason women have CRPS is because men can't take the pain, which is probably true, by the way. But if you don't, then there's probably some kind of hormonal thing. And the neurotransmitter people tell me that the neurotransmitters control the hormones, which in turn I think is the reason that women get this disease and men don't. Or at least for the most part they don't. Okay? Low levels of folic acid, B12, thiamine, riboflavin, B6 have been associated with mood disorders. Too much B6 can actually cause pain. And you have to have a great deal of B vitamins to repair the neurotransmitter function of the brain. So as you can see, the diet interacts with the neurotransmitters, which interact with the B vitamins, which interact with the hormones. And so we're really kind of trying to look at this whole thing as a big picture. I made this the last slide because of this. When anybody comes into my office and they say, my RSD is flared up, I stop them and I say, it's not yours. You don't want it, give it away. Give it to somebody you hate. Okay? It's a disease. Nobody wants a disease. It's the disease. It's the disease that you are going to get rid of. It's the disease we are going to make better, but it's not yours, so don't claim ownership. You have to have a positive outlook. I know it's very difficult. I treat people all day. I mean, I see 10, 12, 14 people a day with CRPS every day of the week. I understand. My mother has the disease. My sister-in-law has the disease, and I got into this before either one of them got it. Okay, I understand. I watch these people outside of an office setting. I get it. But if you don't have the optimistic approach, if you don't find something to smile about, if you don't find a way to invest yourself in feeling better, getting better, and intermingling with people who are like-minded, okay, then there's no hope you're going to get better, because they're going to drag you down or you're going to do it yourself. And so I put the Optimist Creed in, okay, and it's really very poignant. I thank my wife for recommending this to me, as she recommends so many, many things to me as a holistic health counselor and a Reiki master, and wear a cheerful countenance and give every living creature you meet a smile. I just picked one. You can pick any one you like. You can pick all of them. But I think attitude has so much to do. When I get somebody who comes in and they say, I am going to beat this, I am going to get up out of this wheelchair, I'm going to walk, I'm going to go back to work, I'm going to do things, and they dedicate themselves to getting better, they get better. I'm not saying they get all better. I'm not saying a woman in a wheelchair is running a marathon. but better is in grades. And you have to believe. You have to believe in the people you're treating with, the people who are treating you, the people who are helping you, the family members, the friends, but mostly, first and foremost, you have to believe in yourself, because we are, as human beings, are made to heal. That was the way we were made. You just have to find the right pathway. And when you find the right pathway, you get better. So my hope is that you come out of this understanding a little bit more and a little bit different, that there's more things that you may have not known about, which is why I titled the talk that I did. That you go home and you say to your doctors or to your, or your physical therapist, whoever it is, hey, let's look at my vitamin levels, okay? Or let's talk about neurotransmitters. As I said earlier, I have a website called drgetson.com. I walked out without any business cards today, but it has a direct link to if you want to send me an email and ask me a question. I'll answer it myself. I do all of that myself. There's information there. You're going to have the availability to this. You're going to have food for thought. Be your own, be proactive. Be your own best doctor. Ask questions. It's going to drive your doctors crazy, but ask questions and be informed. And if you don't have the answers, as Jim said earlier, fire your doctor and find one who does. Because first, they're not going home at night and suffering. You are. Or your friend or your neighbor or your relative or whoever you may be here for if it's not you yourself. So I will take questions, and if we run out of time, I'll be out in the lobby and answer any questions I have. And please speak up, because I sure don't hear like I used to.
I was wondering if your study with the genetics is just going to be simply with the family members, or is it also going to include the environment, because the same people may be introduced to the same environmental issues, where it may not be genetics but environmental.
The question was whether or not the genetic study that I'm doing is going to include environment, because the people may be introduced, may be living in the same environment. And the answer is, at the moment, it's genetic. Whether we're going to expand it or not will depend upon the answers that we get from the genetic study. I did this because of that link in families, you know, a father and two sons, two sisters, whatever it happened to be. You got to start somewhere. Yes, ma'am.
Now I'm back to the genetic loss.
I keep stepping on that thing.
If you know that you have family members who are getting it, and you know that one of your kids has to have surgery, would you say that kid should also do ketamine?
The question was, if you have a family, I think if I understand you correctly, if you have a family member that has CRPS and the offspring of that child needs surgery, would I buffer that child with ketamine intraoperatively? And the answer is no, okay? Simply because I don't know that the child has it, okay? Unless I had reason to suspect that they did, I will have to make the assumption that they do not until proven otherwise. Because not every, you could have 5 members of the family, 2 get it and 3 don't, so why give somebody an unnecessary drug? Although I will tell you this, ketamine originally was released as an intraoperative drug. It was just to put people to sleep. So it's not like there's any real harm with it. You're just going to have a hard time selling the surgeons and the anesthesia people that. I have trouble selling them a lot of things. Yes, ma'am.
Forgive me if you already mentioned it, but Celebrex, is that something that...
Celebrex is the question. Celebrex is a COX-2 inhibitor, anti-inflammatory. The problem with any anti-inflammatory, and despite the fact that they sell this as being safe to the stomach, it's not. It really quietly erodes the stomach over a long period of time. So if I was going to do something for inflammation, I would first do it by diet and get the inflammatory foods out of my diet. If that didn't work, I would try and find something in a way of an all-natural product to reduce the inflammation. There are homeopathic agents that will reduce inflammation. There are all-natural vitamins that act as anti-inflammatories. There's a whole gamut of things that you can do that don't require you taking that prescription medication.
What's your thought on ketogenic or modified ketogenic diet to address neurosis?
Say it again, I'm sorry.
Ketogenic or modified ketogenic diet?
You know, I can't tell you too much about other diets. Really, I have a kind of limited, it's not my forte. I leave that to people who understand better than I do. I just know that the foods that we talked about in terms of the gluten and all the other are highly inflammatory, and so the recommendation to reduce things that are highly inflammatory is at least about as far as I'm capable of going. But I would not look for a dietitian if I was going to talk about diet. I would look for a nutritionist, or I would look for a holistic nutritionist if you really wanted to do it the right way. There's a school in New York called the INN, Institute for, I'm going to get shot. Institute for Integrative, IAN, Institute for Integrative Nutrition, that turns out holistic health counselors, and they're all over the country. And you can go to the IAN website and find somebody in your area who was trained in doing exactly what you're asking. Yes, sir.
You mentioned the dental aspect of CRPS. On the flip side of that, hypothetically, if someone had some type of oral surgery and a nerve was nicked, can the RSD start there?
Can the RSD start from oral surgery? Absolutely. There's just absolutely.
So that if you had another subsequent injury, like a sprain or a break, it could spread from there very.
It's unfortunate. People that start their RSD, CRPS in their mouth, it's horrible. It may be, from what I'm told, about as bad a pain as any of the pains that there are when it starts in the face, because it just extends up into the ears, the head, and the people just sit and rock in pain. So it absolutely can start from dental extractions in the face. And again, to expound on what she said, if I was going to have a dental extraction and I had family members, that might be the only instance where I might say, you know what, I'm a little afraid, so let's talk about how you're going to do this. If you're having an extraction of a dead tooth, it's not an issue because the nerve's already dead. So you can't get CRPS from a dead nerve. But if the nerve is alive, and let me step aside a second. I'm going to get on a soapbox for a minute. Root canals are the world's worst thing. Root canals cause more problems, not only with nerve damage, but breast cancer, okay, than you could possibly imagine. Now, I'm not here to go into that, but thermographically, we look at faces and breasts and stuff like that. My patient comes in and said, I need a root canal. I said, pull the tooth, assuming that it's not a CRPS patient or assuming I can give them the ketamine. Because root canals just don't get, I hope there's no dentist in here, root canals don't heal. What happens is the little low-grade infection sits there. So if you have CRPS and you have a compromised immune system, why are you going to put yourself in a position to have a little low-grade infection sitting there? And it does, time and time again. So if somebody comes in and says, I need a root canal, I say, there's no way around it, pull the tooth. It's a lot safer. Yes?
So if the patient's tried, like I've had 7 nerve blocks, spinal cord stimulator, all this medicines, done chemo, like a form of chemo injections, everything, and still nothing's working, would you suggest doing the ketamine IV?
Absolutely.
Okay, how do I go? Still don't know how to go about where to find something.
We'll talk after. The question that she asked, though, which is pertinent to the group, is I've tried this and this and this and this and this and nothing works. Would you try IV ketamine? And the answer is absolutely. And I can give you specifics afterward. Yes?
What's your experience with IVIG?
The interesting thing about IVIG, which is immune globulin, there was a doctor in Florida who has since retired who probably 20 years ago was giving people IVIG for CRPS. And everybody thought he was a lunatic. He had no idea what he was doing, some crazy man that was doing this. IVIG is just giving the body immune globulins to help restore some of the immune function that is lost. Does it work? Don't know the answer, okay? It's real simple, it's real safe, and it's certainly worth a try, especially in a patient whose immune system is compromised to the point that they're always sick. If somebody came in and they're getting a cold and they're getting tonsillitis and they're getting earaches and it's time and time and time again, then I would give them some IVIGs to see if I could boost the immune system. Once you start it going, the immune system will roll, and there are oral agents that will boost the immune system made from some of these nutraceutical companies all over the, reputable nutraceutical companies that will maintain it. But it's kind of like, give me the boost, get started, especially for somebody who gets a lot of infections, gets sick a lot. Yes? So if the question is whether or not it's smart to put a port in for somebody who's getting multiple procedures and needs venous access, was a question asked earlier today, aren't you afraid of sticking a needle in a patient that has CRPS? And the answer was that it's a risk-benefit ratio. When I do ketamine infusions on people that I think are going to be in it for a long time, I put a port in them. And I put it on the opposite side of the chest if they have one-arm disease. If the right arm's affected, I put it on the left. Am I running a risk? Absolutely. I think I'm running a bigger risk probing and prodding to do it because the startup is 10 days. So that means you've got 5 venipunctures in 10 days. And that doesn't talk about the blood work that you need and so on and so forth. So we put ports in. I have people who do it on a full-time basis doing it, not somebody that does it now and again. There's a company up by us that just does that. Is it a risk? Yes. Is it a risk that I would be worth taking if I were on the other side? Absolutely.
Thank you. Can I ask the same question earlier without jumping, but
Let me get a little closer and hear you better.
I like the idea of what you were saying about fibromyalgia and CRPS being the same thing, because I've thought that for quite some time. But I read a study recently about doing human growth hormone for fibromyalgia and that they had great success with it. Would that be something that you would, what are your thoughts on that?
Human growth hormone. The question is whether or not I would consider using human growth hormone. And the answer is this. I don't know enough about human growth hormone to even begin to answer your question. And I learned a long time ago that you look really silly answering questions if you don't have enough knowledge. So I'm going to defer on that and tell you that I'm not the guy to talk to because I don't know.
If you have an intrathecal pain pump, can you still do ketamine? Does that interplay at all?
You're saying, can you put ketamine in an intrathecal pump?
Can you undergo ketamine treatments if you already have a...
Oh, yeah, sure. Whether you can undergo ketamine with an intrathecal pump, yeah.
I have one more unrelated question to that. You talked about bladder incontinent issues and the fix going in and getting catheter. Is there something for the opposite problem, the inability to void or problem voiding?
Yeah, the answer is the same, actually. Okay, because of this, understand, as you all do in here, that when the sympathetics malfunction, you never know which way they're going to go. Okay, for some people they have tremendous hair growth, and other people have no hair growth, for example. All right? Most people have the leakage of urine. Some people don't go at all, and they wind up having to catheterize themselves. The young lady that I showed you with the funny skin thing, for quite some time, I mean, her belly, she looked like she was about 7 months pregnant because her bladder kept coming out, unless she catheterized herself every 2 hours. And the answer was the same. We put her in the hospital. She went to a leading center in Philadelphia, and they'd never heard of this. We put her in a hospital, put an epidural catheter in her back. And not only did we get her bladder straightened out, but it's now 14 months later, and she's not ever had to catheterize. Now, I'm not saying everybody's going to be that way, but what it did was it stimulated her body with the ketamine following it up to do what it was intended to do. It just needed that shove. Yes, ma'am?
Can you use LDN if you're on a pain pump?
Say it again.
Or do you have to stop the pain pump?
Well, the question about pain and ketamine, is that what you're asking me?
No, can you use LDN and the pain pump?
Okay.
together?
The problem really is what's in the pump. You know,
Repeat the question.
go ahead.
They didn't hear the question.
Okay, I'm sorry. The question was whether or not, thank you. The question is whether or not you can use LDN if you have a pump that has morphine and other chemicals in it. The problem with LDN, I think, is that it really effectively sort of invalidates what's in the pump to a great degree. It's an anti-drug, and it's really meant to work as an antagonist to other drugs. So I would think using LDN in a situation where you had a continuous flow of morphine, et cetera, okay, would actually make you worse rather than make you better, because you couldn't achieve the level of pain relief that you were getting from the pump because of the fact that the LDN would work in the opposite direction from it. Yes, sir.
This might be more of a warning than a question to everybody. I went to some applied kinesiologist, and he might have helped me a few times, but I went there after I shouldn't have probably, and he made things worse. Like just tapping on parts of your neck, and he locked my arm up once, and then even worse, I went to a myokinesthetic therapist, and she really whacked me up.
The not so much a question as comment was that he went to an applied kinesiologist and a myofascial therapist, which made him worse. It's very sad when I hear that, because There are so many people out there with medical degrees and other degrees who really have no idea. And they think that they're doing something that's helpful, and they're doing something with good intention.
Maybe they get something that they shouldn't, like just barely torquing
Yeah.
on a tendon here, just poof.
So my answer to the group goes back to a slogan that those of us who are old enough to remember from the 70s, which said, if it feels good, do it. You know, when you do something and you walk out of there and it doesn't feel right to you, because it's your body, and instinctively, you really should know that it's not right. Now, can harm be done in one visit? Absolutely. But we tend to repeatedly go back because we're said, well, you know, it's going to take 5 or 6 or 7 treatments. Well, it only takes one to make you feel bad. And I think that if you go someplace, whether it's myofascial release or it's kinesiology or whatever it is, and you walk out there and say, I feel worse rather than feeling better, I would never go back. I mean, it's just the best advice I can.
Back a couple more times over the past couple of years, and
Yeah.
sooner or later, you just get something different.
You know, you're dealing with a disease where the hands-on approach really doesn't do good most times. You know, unless you have somebody who really is tremendously well trained and really understands, they're more likely going to hurt you than not.
Yeah, because in November, I was in pretty much remission. I was able to fish all day, like 8 hours a day, and then as soon as they started
Yeah.
touching me again, just boom, 10 months of down.
Yeah.
Just for like 4 visits.
You just, it's a shame, you just can't go back. I mean, as a group, he did, and I'm sorry for that. Pradeep was talking earlier about mirror box therapy, and I think that's great for someone like yourself, where you have to try and teach your body that your right arm is your left arm and your left arm is your right arm. And if you can find a physical therapist who understands that, it's the kind of non-hands-on approach to what you should be doing and what a lot of people should be doing, because the hands-on stuff is really tough. I mean, I got a lot of people, I have friends who are chiropractors, and I'm an osteopath, so I learned hands-on stuff. And as a general rule, I rarely do anything like that. I mean, I'll do a neck correction on occasion for somebody who I know, but I don't do any of that stuff. And people say, can I go get a massage? And I say, if you go in and they put their hands on you and it hurts, walk out. Because really, the potential for harm in that instance is much greater than the potential for good.
Yeah, I learned the hard way this
Yeah.
year.
And actually you become an unfortunate example for the rest of the room to hopefully learn from what was a mistake from you. Yes, sir.
Do you have any advice as far as finding somebody who knows about this disease? Because if you go to what's a good dentist? Bam, you can find somebody. But we have been to people who have claimed to understand, to know, to treat, to practically cure, only to aggravate the situation and cause a lot of financial headache.
Or be told it's not typical.
I make a living off of seeing those people. You know, there's I'll answer your question in a second. There's a wonderful man by the name of Neil Donald Walsh, who I don't know if any of you have ever heard of, who wrote some books called Conversation with God, in which he claims that he actually talked to God and got answers to a lot of questions. And one of the things that he talks about in one of his dialogues is he said, there are those people who don't know and don't know that they don't know. Okay? And then there are those people who don't know but think that they know. And those are the people that you have been seeing. And they're a danger. Okay? And they are my colleagues. I had a medical school professor tell me one time, you only have 2 jobs. You make people better, or you get them to somebody who can make you better. That's it. That's the only 2 jobs. If you do that, you're going to be very successful. So my answer to you is, call that guy. Because he has a list of people throughout the country that he knows know. And Jim can tell you, and if that means that you've got to travel 300 miles, then you have to travel 300 miles because it's better than what you've been doing. Because they compile this at the RSD Association, and as a general rule, he's right.